So welcome back to our second learning track session. We've been immersed in your needs assessments and reports and know braiding funding is a top priority for you. So we've modified the structure of this session to be able to dive a little deeper into Arizona's braiding strategy, funding sources, partners, and innovations. We also added a bit more time for rich peer-to-peer exchanges in the breakouts. Between now and the May session, you'll work with your TA coaches to find ways to apply what you learned here. On May 16th, we'll gather again with a focus on how to operationalize your braiding strategy. As we begin, please remember to have your Zoom square show your name and your state. It's very helpful to everyone. And please also be sure to mute your mic unless you're speaking. We are recording the session today, including the breakouts for note-taking purposes. Today, we're starting with a few minutes of level setting. So we have a common framework about braiding with funding and the flexibilities we have across multiple systems, health, housing, and social care. Next, we're grateful to have the Arizona team present their approaches to braided funding with some time for Q&A as a large group. Using tax recommendations, states have been paired in the breakouts, but each of the three rooms will have at least one Arizona team member to answer final questions. The facilitators will then guide a discussion about braiding for rental assistance, tenancy supports, and expanding the pool of housing for your priority populations. After 45 minutes in the breakout, we'll quickly close back in this main room. Next slide. In preparing for today, we developed an initial framework of the core elements needed for successful braiding strategy. Because these elements are interconnected, the process of developing a braiding strategy is iterative, not linear. Strategies need to have a shared purpose and identification of the housing, tenancy services, and supportive services that an individual need for that purpose. For example, if your state wants to increase stable transitions to homes in community for people with disabilities, to make the transition, individuals tend to want and need housing rental assistance, wraparound, transportation, and assistive technology. Some may need a personal care aid or their caregiver needs supports. A strategy that will have the actual funding source for those housing, tenancy services, and supportive services that need to be braided. It will consider who gets the funding, a program or an organization, or is it an individual? The braiding strategy incorporates the organization delivering the housing, tenancy services and supportive services. As we heard in March from Massachusetts and North Carolina, another strategy element is the infrastructure or apparatus needed to support braiding operations across organizations and systems. Think about billing, data, provider capacity, communications, and more. And finally, braiding strategies tend to entail alignment of program funding requirements, as so many of you are working on. Listen for these elements as Arizona presents. Also, after the TA session, please send us feedback on these core elements in the discussion board on the TA site. Staff will drop that link in the chat. Next slide. Today, we have the honor of hearing some brief remarks from one of our federal leaders, Dr. Richard Cho, who is the Senior Advisor in the Office of the HUD Secretary. Richard, the floor is yours.
Great. Thank you so much, Ryan. And I will keep this brief. I know I'm really excited to hear from our colleagues in Arizona, as well as to make sure we have plenty of time for the peer-to-peer discussions today. I want to just say how excited I am again about this Housing and Services Partnership Accelerator and about today's session in particular. For me, the Housing and Services Partnership Accelerator is not just a technical assistance effort. This is really a chance for us to work with some of the leading states across the country to bring to scale housing and services, which we know is the solution to solving homelessness for people who have behavioral health needs or other complex health needs, as well as to support community living for people with disabilities and other complex health needs. And I think from my perspective, the Housing and Services Partnership Accelerator really gives us the opportunity to bring to scale that combination of housing and supportive services that we know is critical. Just to oversimplify things for a moment, really this is a problem of how do we solve two parts of an equation. One is how do we ensure that we are bringing housing resources to scale? That means rental assistance, capital dollars, as well as housing-related services, but also the wraparound supportive services that helps people to find homes and stay in their homes. And while we know that we still don't have enough resources to solve the housing side of the equation, and again, we're working on that, and HUD has done a lot to try to scale additional vouchers as well as homeless assistance grants over the last few years, we still know there's a significant need. I think we now have an opportunity to at least solve in your states the services side of that equation by really unlocking the flexibilities under your Medicaid programs and really enabling us to leverage Medicaid as the primary source of those housing-related services that helps people to find a home as well as stay in their homes. If you heard me right there, I did say primary. I think there's a real opportunity here to ensure that Medicaid serves as the kind of backbone of these housing-related services. But of course, Medicaid can't be the only part of that equation. This really means that we need to figure out how do we center this work on Medicaid supports, but also to wrap around other resources, whether that's HUD grants that fund supportive services, grants from SAMHSA, or even your state and local resources. So that's really what today's session is all about. It's about how do we blend and braid these resources, both blend and braid supportive services resources with housing resources, but also blend multiple different sources of federal, state, and local resources to fund those housing-related wraparound supportive services. And I think I'll just say this, we know we face a lot of challenges in doing this. We're working with various federal, state, and programs that aren't meant to fit together. I think I've given the analogy that it's a little like trying to build something with Legos and Tinker Toys and Lincoln Logs. You know, these are not kind of pieces that were meant to fit together, but here we are, and the job in front of us is figuring how do we take programs that weren't necessarily designed to fit together, but integrate them in ways. I'll also say that we're dealing with probably some culture and communication challenges across different sectors. Now, for those of us who work in the housing and homelessness space, blending and braiding resources has always been part of the equation because we're working in an environment of fairly significant resource scarcity. And so the question's always been, how do we layer together different levels of and different programs to be able to create affordable housing or permanent supportive housing? In the Medicaid space, the conversation is often different because Medicaid is a much larger system. It's an entitlement program. It is really about benefits. And so often the thought process is really about how do we put into place guardrails around these supports. And so I think sometimes when housers and Medicaid folks come into the same room, there's a little bit of talking past one another because in the housing space, we're often thinking about how do we creatively blend and braid resources, and Medicaid, the worry is always about how do we not ensure that we're imposing these guardrails. And so what I want to do today is to challenge all of us to say that at least from a federal perspective, we want to make sure that federal rules and bureaucracy is not the obstacle to the extent that it needs to be, and that in many cases in your own states, challenges that you faced where you felt that federal rules or federal regulations are standing in the way of your ability to blend and braid resources. I found in my federal service that more often than not, the answer to those challenges is that there's actually a way to solve some of these issues. And so what I want to challenge all of us today to do here today is to say, to bring those questions, things that you might not have thought that are possible in terms of blending and braiding resources. Let's ask that as a question rather than take that as a given, because I think really the chance is for us to here today is to find a solution to be able to make these pieces fit together. Again, without further ado, I'm really excited to hear from our colleagues in Arizona who've already worked and made a lot of progress in solving some of these challenges and figuring out how to integrate these resources. And again, moving closer to the day when we can fully scale housing and services to end homelessness, as well as to ensure that people with disabilities have the right to community living. So with that, I'll turn it back to you, Ryan.
Thank you so much, Richard. It sounds like we might have to do a Lego challenge at our upcoming in-person convening. I want to next welcome and thank Elizabeth DaCosta, Director of Housing at the Arizona Healthcare Cost Containment System, and Margaret Adams, Special Project Administrator for the City of Phoenix, for presenting. After they speak, we'll have some time for questions. And before we do that, we'll then shift to the breakout sessions. So Liz and Margaret, take it away.
Excellent. Thank you so much. So glad to be here speaking with you all about this important topic. We can go ahead and go next slide. So yeah, as mentioned, I'm the Director of Housing with the State Medicaid Agency Access in Arizona. And quickly, I'll just pass it over to Margaret to do an introduction herself.
Hi, good afternoon. I'm Margaret Adams with the City of Phoenix Office of Homeless Solutions.
So really cool, the Medicaid agency and then also the City of Phoenix Homeless Service Solutions working together as core team members and able to present to you all today. We can go ahead and go next slide. So we see these braids here. This is our goal and our mission is to get to this colorful, brilliant ability to be able to seamlessly braid our funding resources together to be able to help serve and support members in need. We agree the core elements of a braided funding model first include a clearly defined purpose. So we all want to make sure that we are striving towards that same goal. And then from there, we can really identify all the different interventions that are going to be necessary. So just examples as it pertains to housing are, of course, the rental assistance, the supportive service, but then also thinking about the incidentals like deposit assistance and how the member is going to be able to have furniture in their home when they initially move in. And then from there, identify those fund sources. So who are all the potential funding opportunities throughout the state to be able to help us serve our purpose? Who are the partner organizations that we need to collaborate with in order to be able to meet the goal? And then really important, we'll go into it much further in detail throughout the slides, but the alignment of administrative requirements wherever possible. So how can we take the Lincoln Log requirements and the Lego requirements and try to align them so that we can essentially build a braided funding model that will be able to be sustainable? We can go next slide. Really important, though, to understand is the history of the Arizona Medicaid housing landscape. Because when you hear Medicaid housing, it's pretty unusual. But we in Arizona had a class action lawsuit. It was the Arnold v. Sarn lawsuit. And we were able to work towards settlement. And in that settlement, we have a requirement that we increase the number of supportive housing slots in Maricopa County. There are a lot more requirements in those exit stipulations. And so I have put that link there with the Arnold v. Sarn settlement link. But really what came from it, though, was the state needing to look at how are we going to meet the requirements of that exit stipulation. And so we actually received a state appropriation of general funds of $29 million to be able to cover rental assistance for eligible members. And most of those dollars are focused on members who have an SMI designation in the state, but we also have some funds that can cover rental assistance for members who are considered general mental health and substance use disorder to be able to receive a rental subsidy to be able to live in the community of their choice. If we were a public housing authority, we would be the third largest in the state. And then we also received, and this is very unique and cool to consider when you're looking at fund sources for a braided funding model, but the state has a Senate bill where we take unclaimed property throughout the state, and then it is invested and Access, the Medicaid agency, receives $2 million annually from those funds to be able to do acquisition and renovation of actual properties that will be dedicated to members with a serious mental illness. And so we actually contract with developers and housing contractors. We partner with low-income housing tax credit properties now to be able to implement these fund sources towards those units so that we can expand units across the state. And currently we have 130 properties that are under CC&R deed restriction that support nearly 700 Access members. And then the last piece, the actual Medicaid covered service piece, is the supportive services. So we really quickly recognized how important it is that we have the dedicated wraparound support services to be able to support members in those various interventions. And so in our contracts with our managed care organizations, there is a lot of language around their requirements to support the permanent supportive housing model, to have a network of providers that can provide community-based services to members. And I listed also the link to our ACOM 448 policy that goes into detail around this. We can go ahead and go next slide. And for the purpose of today, though, we want to try to focus in the conversation because there's a lot of braided funding that's happening around the state. But we wanted to talk about a specific project that we were able to do with the City of Phoenix Housing Choice Vouchers. So you can see we needed to make sure that our core elements were aligned. So we had to identify what our purpose is and then communicate out our strategy. And so our strategy for this specific project was to leverage Medicaid support services to in turn receive housing choice vouchers from public housing authorities and be able to target those referrals to members who are high cost, high need within the Arizona healthcare system. And the next step was to then identify the fund sources. So we identified the City of Phoenix housing choice vouchers, our Medicaid covered services, and then also worked in partnership with Valley of the Sun United Way, where they covered the incidentals. So the providers who performed the community-based services had direct access to deposit assistance, eviction prevention funds to be able to cover furniture and move-in items through that Valley of the Sun United Way grant. And then we identified additional partner organizations to be able to provide those covered services. The exciting thing about this too is really that we already had our state appropriation of general funds that was housing nearly 2,500 members on an annual basis across the state. We saw the tremendous benefits of that, and so we needed to expand the housing resources that we were able to access. So the result was the City of Phoenix Public Housing Authority allocated 275 vouchers to this project. And very unique, this is the first time that the health plans were actually able to refer to those housing choice vouchers. So they could really look within the Medicaid system at members who were considered high cost, high need, who were most in need of those resources, and submit the referrals. We can go ahead and go next slide. And so this is what we talk about when we talk about those Medicaid wraparound housing services, which I'm not sure, you know, the level of familiarity across all the different states participating in the Accelerator, but a very important slide from our perspective, because as we work on training access registered providers on how they can provide permanent supportive housing services to their members, this is the process. So these are the covered services that they're able to bill. You can see we have case management, pre-employment training, supportive employment, peer support services, health promotion. And then I also listed out those various HCPC codes that are tied to those covered services. And then we can see in the next column we have, well, and these are the related pre-housing activities and then housing sustaining activities that the provider can provide to the member while they're encountering for those services. Glad to see, Emily. Thank you so much. So yes, and right now though, those are usually off of 15-minute increments. And so what's happening is when there's a registered provider who's providing these services to members, they're needing to diversify their codes and use 15-minute increments. There's a lot of administrative challenges that take place when they're using the current infrastructure to be able to bill for the supportive services. The other thing that's really important to note is we have a lot of policies and procedures around this, right? They must be an access registered provider. They're likely going to need a very robust health information record, EHR. And in addition, they're going to need to make sure that they follow our policies and procedures around assessment and treatment planning, which usually requires at times like a 3 to 4 hour assessment to really get in depth with the members to be able to articulate medical necessity that then informs the integrated care plan, where these services get added for the frequency and duration for them to go out into the community and provide to the member. Additionally, it requires an overview from an independently licensed clinician who's signing off on the diagnosis and the care plan. So although it's available, just a lot of challenges that we've been able to recognize when it comes to using this model to support the permanent supportive housing services. We can go ahead and go next slide. So you saw on that other slide, we were really kind of getting our yarn together, but we were excited to have the 275 vouchers allocated to us from the City of Phoenix. We knew that there were a lot of challenges and we had a lot of lessons to continue to be learned. So what we found was really important was that we actually took the tape and taped down the fund sources in our braided model so that we can focus it in more heavily on a specific project to really be able to get the lessons learned. So of the 275 vouchers, we were able to get 50 of them allocated to this Project H2 program, where we really worked in partnership with our Governor Transition Office, Access, the Continuum of Cares, to really try to target in our purpose and identify additional areas of learning to be able to actually inform our 1115 waiver, which we'll get to. But that project was able to then use some of our SMI Housing Trust Fund for the bridge subsidy. And I'll go into an example of that. But basically, we had some funding internally at Access to cover the acquisition and renovation of new property. And we wanted to be able to modify that legislative language to be able to also cover rental subsidies. And by doing that, we were able to create a bridge subsidy program similar to what we're trying to do under the 1115 waiver, where we partner with public housing authorities. We use that SMI Housing Trust Fund rental assistance as the fund source that's covering the rental assistance for lease up, with the goal of then transition to a public housing authority within a period of time, as soon as those housing choice vouchers come available. We also expanded our PHA, so we moved beyond just the city of Phoenix and opened it up to the city of Tempe, and then also the Housing Authority of Maricopa County. What we found was that when the Medicaid providers were trying to outreach the members, they had a long period of time before they could actually complete that full assessment and that integrated care plan. And so we needed to start leveraging alternative resources to be able to perform the outreach services. So we worked on also looking at our PATH programs across the state. That's a SAMHSA funded outreach program, and using that PATH team to be able to do the outreach work for members who have a serious mental illness designation or have a mental health diagnosis that are not yet adequately connected. We also were continuing to leverage our Medicaid supports. And so we did a lot of tracking of the data to try to figure out, well, what's taking so long? Like, where are our greatest areas of opportunity? So you can see in that intake to briefing. So that's the time when we've identified this member as eligible until the time they actually get to the Public Housing Authority for their briefing. We know that we need to get documentation for them. They're going to need some financial support to cover birth certificates. And then what we found was a major gap in that area was that the public housing authorities all had different applications. And so sometimes the provider would complete an application for a specific housing authority, but then it would be determined, oh, they're going to be referred to, say, City of Tempe or another one. And then that provider would need to go out and meet with that member and complete a completely different public housing authority application. So just an interesting thing we found where we worked to try to align the applications with the public housing authorities from there. And then the other thing is the search time. So we know that there's concerns for available units in our community, but from the moment the member was briefed and actually had their voucher, it still took over 90 days. Yeah, sorry, over 90 days for them to be able to actually find a unit, complete the application process with landlords, and then get the inspection complete and be able to move in. We can go ahead and go next slide. And this is cool too, because it really was like a Medicaid access-led initiative with managed care organizations, but we are striving towards this collaboration with our COC programs and the use of the homeless management information system data. So we can see that from HMIS, the age of the populations that were served through this program, with over 14 members being over the age of 62. And then we can also see next to it is the HMIS entries for those served. So the average length of time for members served in this project was nearly 10 years. And then their total shelter stays combined, so all the times they stayed in shelter, was over 3,000. And then the last one, we can see that almost 14 members had more than 200 entry exits into that homeless management system. So individuals kind of cycling through the homeless management system at a very vulnerable age who ended up getting referred and served in this program. We can go next slide. I'm going to pass it over to Margaret.
Thanks, Liz. You know, this is was so great when we launched this effort. But we did have some challenges and some of the lessons learned that we're trying to sort of reestablish in this new pilot that we're embarking on now. But we had a real mismatch of expectations from the Public Housing Authority, and we really didn't have very much visibility across the partners to determine that services piece. So we lacked a lot of there was a mismatch of expectations from the Public Housing Authority to the REBA, or the Regional Behavioral Health Authority, related to the level and intensity of services that needed to be offered for the folks that were being assigned to these housing choice vouchers. We also had challenges around data and outcomes. So even though we met early on and, you know, really did try to craft sort of a shared mission and vision for this effort, we didn't have you know, really strong data sharing agreements or outcome goals related to that on the implementation side, right? So our Public Housing Authority wasn't getting data or performance reporting from the services providers, and there was just a real mismatch on our ability to evaluate how these projects were performing. We also had some challenges just getting referrals from our coordinated entry system. So, you know, we really wanted to make sure that we were sort of baking in that sort of system piece, but because we had all of the different eligibility pieces going, and then as Liz mentioned, you know, the variations between the PHA expectations, we did have some challenges just making sure that referrals were coming in timely. And that really led to some significant project vacancies. And from the PHA side, you know, that's just not something that they want to see. And it's not something that's going to allow us to grow and secure more vouchers moving forward, right? We had at our highest, we were at a 79% lease up rate with these vouchers. And so that was really a challenge for the Public Housing Authority and a challenge for us because we know we have folks that need these vouchers desperately. And for whatever reason, we weren't able to get them leased up. We also just sort of had, you know, again, as the project moved on, we did have some, you know, that staff changes and partners were, you know, siloing again. We had lags in communication. And so again, without sort of continuing to recenter on that shared vision and goals, there really wasn't a process for us to raise a flag when challenges were coming in from any of the partners. And so that's also something that we're really taking into our next effort. And then finally, just, you know, when like having that shared, you know, sharing that population and priorities, when we're bringing together different sectors, right, the Behavioral Health Authority, Homeless Response System, and the PHA, you know, this was framed up really well, really nicely up front, but we can often use the same words and mean something totally different for each entity. And so having those shared definitions, really centering on those shared definitions, making sure that we're all operating with a shared language, because anytime you're working on that sort of cross-sector alignment, like you've got to have a translator, right? Someone who can really ensure that communication is clear, and someone who sort of speaks homelessness doesn't always speak health systems or housing. And so really having that that translator, someone who, you know, speaks multiple sector language is really valuable. So those are some of the big things that we ran into with this effort. I'm going to go to the next slide.
Thank you so much, Margaret. And yeah, and so on our side, so important to hear the results from the Public Housing Authority's experience and the Homeless Service Department at the city's experience so that we're working towards continuous improvement. The next two slides are just going to be or three slides are going to be some examples to the language. So from my perspective, this is really where you get to the improvement of a braided funding model is the language that you have in contract that speaks to the entire thread of what you're trying to braid essentially. But the first is actually the revision, the example of the legislative revision that we did to the seriously mentally ill housing trust fund, where you can see we shifted from only being able to do property acquisition and renovation to also adding in the rental assistance. And then the one below is language from one of our contracts with the Public Housing Authority from our Bridge to Subsidy program. So one really cool thing that we did that we're going to continue to try to highlight through the Housing and Health and Housing Opportunities waiver is the linkage bonus. And so really placing the incentive in the goal we're trying to achieve, where we're going to be covering the subsidy for a period of time. But what we're really looking for is that transition to a housing choice voucher and then having that linkage bonus as the incentive. We can go next slide. And then continuing to look at all potential fund sources that are available to be able to bring them and fold them into the braided model and contribute to your goals. So when the ARPA dollars came out, we applied for mental health block grant ARPA dollars to be able to support the infrastructure of new providers being able to onboard as permanent supportive housing providers across the state. And so the key thing with these examples is that we distribute these funds to the managed care organizations, and then we require in their narrative that their end goal aligns with what ours is, right? That they are going to be supporting these providers with being able to shift from grant funding to encountering as they're providing the electronic health record and they're teaching them on encountering capabilities, as they're looking at their rates to make sure the rate is fully covering the cost of the position at the staff to load staff to member ratios that we're looking for. So that's in the managed care organization narrative, but then we also need to see that thread go all the way through to the provider so we're sure that everyone is clear on the goal that we're trying to achieve. So what you can see here is This is an exact example from the provider's budget where they recognize that this is going to be a percent allocation to the grant, not a fully covered position, with the goal to tier the funding from the grant over to encountering in years to come. We can go next slide. This is just another example of the exact language from one of our budgets where there may be some providers in different stages. And so this provider speaks to the FTE decrease to set from 75 to 25% effective July 25, and then them working closely with the health plan to ensure encountering feasibility. We can go next slide, and we're getting ready to wrap it up. And so really what we did was we used all of those lessons learned from that Phoenix 275, from focusing it in more heavily on the Project H2 program to inform the negotiations when we moved towards the 1115 waiver expansion for Arizona to be able to cover the health-related social needs services for members. And that's our Housing and Health Opportunities program. And the most important thing we've identified is our continued partnership and alignment with states, throughout the state, with municipalities, and then with the COC alignment. And I'll pass it back to Margaret to speak quickly on this.
Sure, thanks, Liz. So we have this new opportunity with Access. And so our Office of Homeless Solutions, which is relatively new for the city of Phoenix, we're working directly with our PHA to have an MOU that will allow us to take those allocated vouchers and have OHS have a little bit more control over sort of how this project is operated. So the city of the Office of Homeless Solutions will hold the services contracts, and we're aligning all of those goals and outcomes with Access directly. So working with Liz on our contract language, making sure that we're going to work on how do we, and taking over that referral process to make sure that we reduce those vacancy rates and take that priority population from the 1115 implementation, and then really baking in that data sharing and like evaluation up front. We'll do a BAA or data sharing agreements directly with Access, and as Liz mentioned, that contract language alignment. So all of those are things that we're really taking into this new pilot.
It's excellent. Yeah, so we can remove some of the administrative burden from providers. When we have aligned criteria across our contracts for multiple fund sources they may be receiving, well, then they maintain the same file for their members, the same backup documentation. Their staff are all trained on the same outcomes that they're trying to achieve, rather than maybe 5 different sets of outcomes for different fund sources. We, through the Housing and Health Opportunities, found how important it is to have the outreach and education intervention as an opportunity for our providers, so that, and we were able to receive approval of that through our infrastructure budget. So we're going to have targeted outreach teams that can go out into the community, develop relationship and rapport with members, and help connect them to the health home services, to the pre-tenancy services, prior to them getting that assessment and treatment plan done. Also the short-term rental assistance, very excited about that. And as a part of the braided funding, it's a matter of aligning application processes again, and then continuing our partnerships with public housing authorities so that there is that long-term subsidy that members can transition to. And then I'll wrap it up with the pre-tenancy tenancy sustaining support. So what we've done in our waiver is really try to design the pre-tenancy tenancy supports in a way that corrects some of the issues and challenges we found through this project. And so the first is that in order for a provider to be able to implement these services, they do not need to do a full biopsychosocial and integrated care plan. They're not going to be providing clinical services. They're going to be focusing on housing stability and income stability. So the screening tool they're going to need to complete before they can implement services is the health-related social needs screening tool, which takes maybe 15 to 30 minutes versus the 3 to 4 hours for the biopsychosocial assessment. And then it'll be a housing care plan, not an integrated care plan that talks about all the medical and behavioral health services they're going to receive, but just specific to their independent living plan related to housing. And then a per member per month rate. This is really important for us so that we can shift away from providers focusing so much on value of service, trying to get those 15-minute increments to be able to cover the cost of their staff and their program. We want to have it covered through the per member per month rate. So they are focusing on outcomes. We want those direct service staff to be able to focus on trauma-informed care and how to get a member connected to a primary care physician, not necessarily an expert at how they bill Medicaid. So all the result of that will be clear reporting process requirements that focus on member outcomes, as I said. And with that, thank you so much for the time. We will pass it back over to Ryan.
Wow, thank you so much, Liz and Mark.